Welcome to Horizon Medical Education Podcast, concise, evidence-based audio lessons for clinicians worldwide. For supporting notes, accreditation, certificates, and access to all our courses, visit our platform at www.horizonmedicaleducation.com. And just as a reminder, this podcast is intended for medical professionals and for educational purposes only. It does not replace clinical judgment or local guidelines. Episode 7. Postpartum Family Planning, Part 1. I'm Minnie, and I'm delighted to be joined today by Dr. Rob Burnie. He's an obstetrician and gynaecologist at Lewisham and Greenwich NHS Trust in London. And also, Rob has worked in Sierra Leone and is the chair of the Friends of Nixon Memorial Hospital, Sebwema, in Sierra Leone. Welcome, Rob, and thank you for taking time to share your expert knowledge with us.
Thanks so much for having me. As you said, I'm a jobbing obstetrician and gynaecologist based in London, but I suppose I have a dual life, also working in rural Sierra Leone. And I first got involved in some of the healthcare delivery in Sierra Leone as a enthusiastic but probably slightly naive medical student when I went there to do an elective 15 years ago. And I've stayed in touch with that particular hospital ever since, working both clinically and with an involvement of training healthcare staff there. And I've had the pleasure of chairing a small UK-based organisation that helps to support the hospital. And we're involved in helping training staff, developing the hospital's infrastructure, as well as some community health work. And it was a pleasure to help deliver some work on postpartum family planning training in Sierra Leone. And I think it's one of these vital aspects of healthcare delivery that is applicable everywhere in the world you practice. And I see the relevance of it both in Southeast London on a day-to-day basis, as well as in rural Sierra Leone.
Yeah, fantastic. That's partly why we're doing this course, isn't it? Because you delivered it out in Sierra Leone, and because it's so useful, it's going to be brilliant to be able to reach a much wider audience with it.
Yeah, absolutely. It's something that I'm incredibly passionate about. And in my day-to-day job, I know a lot of doctors and healthcare workers get excited about doing exciting things in obstetrics and maternity, like delivering babies and doing cesarean sections. But I always explain to a lot of the colleagues I work with that the biggest thing we can do to have an impact on women's lives is really offer and discuss contraception. That is one of the most effective tools in our armory, as it were.
Yeah.
So our main kind of tip from this course is that ideally all women, including adolescents, should leave their birthing facility with a method of contraception.
In the course, we're going to discuss postpartum family planning, and we're going to cover why it's important and family planning methods in the postpartum period. We're going to talk about the benefits to mothers and babies of birth spacing through the use of family planning, and obviously the wider family and community, and a bit about counselling techniques. Why are we discussing it? Maternal health remains a major global concern since pregnancy and childbirth are the leading causes of morbidity, mortality, and disability among women of the reproductive age group. Globally, more than 9 out of 10 women want to avoid pregnancy for 2 years after childbirth. And according to the DHS, that's the Demographic and Health Surveys, according to their data, from 21 low and middle income countries between 2005 and 2012, almost all, that's about 95% of women from delivery to 12 months postpartum wanted to avoid pregnancy in the next 24 months. So that's 2 years, but less than 1/3 were actually using any method of contraception. So 61% of postpartum women had an unmet need for family planning.
We know that maternal mortality remains a really key issue affecting women of reproductive age across the African region. And although we've seen a global decline in the maternal mortality ratio to 34.2% between 2000 and 2020, still more than 2/3 of these deaths occur in the African region. Over 300,000 women die in pregnancy annually, which equates to 830 deaths every day. And the vast majority of these, it is an awful lot. And it's one of those things that demonstrates the inequity in healthcare provision, that the vast majority of these are in lower middle income settings. And I think one of the other key things to note is that around a quarter of these maternal deaths are in young women, in adolescents. And they're really a key group that I think we need to focus on because they are at most risk of adverse outcomes. And the causes of maternal death haven't changed hugely over the last decade. Bleeding still remains one of the leading causes, kind of causing around 27% of all maternal deaths. And despite improvements in blood pressure control, preeclampsia and other hypertensive disorders do account for a large group at 16%. We know that complications resulting from an unsafe abortion practices contribute to 8%. Infection and sepsis is still up there at 7%,
Yeah.
as is embolism at 7%.
And embolisms, mainly pulmonary embolism.
Exactly. That women in pregnancy, and particularly in that postpartum period, are really at very high risk of venous thromboembolism, so clots in the legs travel into the lungs. And I think it's important to remember that later on in other modules when we discuss some of the risks of contraception, because there's a lot of information out there about the risks of having blood clots associated with using contraception. But I think it's important to remember that being pregnant is by far a greater risk of blood clots than any form of contraception.
Yeah, it's good to keep that in mind, isn't it? That sort of balance of risk.
Yeah, 100%. I think maternal health on the kind of global stage is more a dominant issue. And there are lots of strategies in place to try and help these causes of maternal death. And I know I'm teaching on a course up in Edinburgh in a few weeks' time, looking at emergency obstetrics and how to manage these emergencies in low resource settings. But I think we have to remember that avoiding these unwanted or unplanned pregnancies in the first place through meeting contraceptive needs is by far the most effective tool we have in tackling maternal morbidity and mortality.
Yeah, I think that's a really important point. And on the transcript, you'll see that we've got a couple of data maps which show you the maternal mortality ratio from 2020. You'll see the hotspot on there. Is there anything you want to say about those, Rob?
I think one of the key things is that when we look at women that die of pregnancy, we have to really consider the number of those pregnancies that were planned or wanted. And I think when we will look later at the maps of unmet need in relation to contraception, they really mirror what we see in terms of the places where women sadly die of childbirth. So there's a clear correlation between when we address contraceptive needs, we see those falls in maternal morbidity and mortality.
Yeah. As you've mentioned, pregnancy and childbirth also carries a risk of harm, and this is what we call morbidity. So for every death, 20 to 30 women suffer severe injury or disability. That's known as a pregnancy-associated morbidity. Much of this morbidity following childbirth emerges 6 weeks or more after birth and can be comparatively less visible or completely ignored. And the most common conditions include dyspareunia, so that's painful intercourse and sexual dysfunction, lower back and perineal pain, urinary and fecal incontinence, anxiety and depression, and secondary infertility. There are other less common complications, and obviously, Bob, you're right in the firing line of all this, and so you'll see this on a regular basis. But it includes things like post-traumatic stress disorder, psychosis, obstetric fistula, which through a lot of charitable work, I would say is probably one of the best known postpartum morbidities, peripartum cardiomyopathy, thyroid dysfunction, nerve injury, and venous thromboembolism, as we've mentioned before. These can all still have a significant impact on a woman's life course.
Yeah, and I think it's really important to not forget this morbidity, that it's easy to focus on the mortality. And a lot of these conditions, including things like when there are continence issues, can be really quite stigmatizing for women, and they can result in feeling quite estranged from their family and community. And there can be really quite negative consequences in terms of emotional, psychological, and physical health.
Yeah.
And when I think of patients that I've looked after that have had complications arising from their pregnancy, often these have a long-lasting impact both on their health and well-being, but also the wider impact in terms of how they can financially support themselves and how their whole family setup can work. And the schematic that we've borrowed below from a recent Lancet article shows quite how wide some of these complications are, and in relation to both those immediate things that can cause problems, as well as things related to subsequent pregnancy, as well as other issues that can really kind of impact life in the long term.
What is tocophobia?
So tocophobia is essentially a fear of contractions or a fear of childbirth and labour. And it can either be primary, whereby women who have never given birth have an innate fear of contractions and a fear of a vaginal birth. It can also be secondary, related to an adverse birth experience in a first pregnancy, So if a woman's had a complicated or traumatic delivery, this may then feed into quite a severe fear, and it can really be quite a debilitating fear of
Mm.
childbirth, meaning that potentially a woman may avoid pregnancy, which may have impact on her family and community perceptions.
Yeah.
Or if she does fall pregnant, could have a big impact in terms of the worry and anxiety during pregnancy, or the request for a cesarean section birth instead of a vaginal birth.
That's great. Thank you, Rob. And that's just one of the long-term conditions that arise from childbirth that you can see on the schematic on the transcript. This gives a powerful visual overview of the medium and long-term conditions that can impact women for years following childbirth.
And I think as healthcare providers, particularly those that are involved in maternity care, that we see the snapshot, we see this moment of birth and perhaps a few days afterwards where women are under our care on the wards. But actually, often this long-term consequence is quite hidden to us. And actually, it may be that they see a nurse in the primary care setting or a community care setting, or these issues only come to light when there's another pregnancy and we're able to revisit them. So I think a lot of this is hidden, and we forget about when a woman leaves the birthing facility, what happens thereafter. So it's, I think, really good to emphasize these issues.
So a lot of this will be handled by primary care, really.
Yeah, exactly. And I think it's key that it's on the agenda and in the minds of healthcare professionals when they are seeing women in that either short-term postpartum period or actually in the years after they've had a child, because these issues do persist. I reflect on women that I've looked after, and this is just my personal experience in Sierra Leone, and on the outcomes where women have had really quite challenging experiences. I remember on a Sunday morning, a woman who was in her late 30s, I think 38, 39 she was, and she had 8 children at home.
Gosh.
And very sadly, her baby had been lying sideways in the uterus, sideways in the womb, so a transverse lie. And she'd been in labour for many days in the community and unfortunately been inappropriately given some medication, some oxytocin to try and make her contractions stronger, as they felt this was the reason she hadn't given birth. But sadly, this has resulted in her uterus rupturing, which unfortunately resulted in a stillbirth for her baby. And for the woman herself, we managed to take her to the operating theatre, and she was very unwell when she arrived at our facility, had very low blood pressure, fast heart rate, and she required a blood transfusion. At her surgery, she had around 3 litres of blood in her abdomen.
Gosh.
And incredibly grateful that through the team that were looking after her, that she survived. But actually, she required being in hospital for, I think, 4 weeks in total. And even after she was discharged, she had long-term issues with pain after her surgery, had several readmissions to hospital with infection. And although she survived during that time, she wasn't at home looking after her 8 other children that didn't have their mum for that period. It had a big financial impact on the family, not having her at home because dad had to stay look after the children, which impacted on his ability to generate income. And you kind of reflect that at 38 with 8 children in a family, I didn't know her full context or background, but you do have to question whether she had the opportunity to consider whether she wanted to become pregnant again, or anyone had ever discussed the opportunity for contraception with her.
Yeah, absolutely.
You see it at both ends of the age spectrum, women like her that have had multiple children. But also, I saw teenagers on a fairly frequent basis, and they struggled with complications. I remember a young woman who, although we were able to transfer her to the fistula unit in Freetown, sadly had both a connection between the vagina and the bladder and the vagina and the rectum, that her morbidity over the next kind of 2 years post-delivery was incredible, being away from her family, the time she had left education. So these things really do have a huge impact on life course.
And what about cost for the treatment? How was that met?
I think it depends on what setting one is practicing in. I find in the settings I've practiced in low-income settings, although in a perfect world, healthcare delivery may be free at the point of use for patients. Often there is an element that is required to be paid for, whether formally or informally, and that has a big impact. And actually, in settings where resources are limited, it has a big cost on the healthcare institution itself that is delivering care as well.
Yeah, lots to think about there, isn't there?
Yeah, I do feel that it's an area that if we address it, it can really have a big impact, particularly with our younger women, our adolescents, because we know that they are at highest risk of complications and sadly dying during pregnancy. And we know that risk of death is highest for girls under 15 years. And in many low income settings, actually in adolescence, complications resulting from pregnancy and childbirth are the leading cause of death in this age group. And I just
Mm.
think this is so tragic that essentially it's a really preventable issue.
Yeah, I can see why you're so passionate about this topic.
Yeah, no, it's I think it's one of these things that shouldn't be complicated and is definitely doable. And I think that's why it's fabulous that we're talking about it today.
Yeah, so if you'd like to know more about postnatal morbidity, perhaps we can persuade you, Rob, to come back and do another course on that particular topic. The main issue for this course is to talk about the postpartum family planning. So what is postpartum family planning and how can it help? Just to start with a definition, we always like a definition on Horizon. So postpartum family planning is defined as the prevention of unintended pregnancies and closely spaced pregnancies through the first 12 months after childbirth. But it can also apply to an extended postpartum period up to 2 years following childbirth, according to the WHO in 2018. So this includes, and you might see these terms when you're reading other articles about contraception and postpartum periods. So immediately postpartum, the IPPFP, so that's within 48 hours of birth. During early postpartum, the EPPFP, and so that's 48 hours up to about 6 weeks postpartum. And then an extended postpartum period, as I've just mentioned, the EPPFP, that's 6 weeks to 1 year after delivery. We know short birth intervals increase the risk of health of both the mother and the child, such as risk of preterm birth, low birth weight, and small for gestational age of the baby. And it increases chances of chronic undernourishment, stunted growth, and child mortality.
And I think the key thing is that using family planning during that postpartum period really helps women to space births by at least 24 months. And we know this can help reduce maternal and child mortalities by 30% and 10% respectively. And these figures came from a report on postpartum family planning in Ethiopia, Malawi, and Nigeria back in 2015.
It seems a long time ago, but it's still relevant, I think.
It's still relevant. And I think those figures are huge in terms of actually the impact they can have both on maternal and child death rates. When a pregnancy occurs less than 6 months after a previous delivery, this is the time when the risk of low birth weight is really particularly high and the risk of prematurity doubles. Children born less than 24 months after a previous birth are 60% more likely to die during infancy than those born more than 24 months.
Yeah, it's amazing statistics, really, isn't it?
Yeah, I think these are particularly relevant to low income settings where there are obviously other contextual factors that have an impact on childhood survival.
Yeah.
But yeah, incredibly important. The sad thing is, despite knowing the benefits of birth spacing, this kind of key interval of ideally 24 months, there still remains a big unmet need in contraceptive provision.
So when we were discussing this, Rob, I wanted to have a look at what this unmet need meant. According to WHO and their sort of definition of unmet need in this context is women with an unmet need are those who are fecund, so that's married or in a consensual union, and sexually active, but are not using any method of contraception, and they report not wanting any more children, or they want to delay the next child. The concept of unmet need points to the gap between women's reproductive intentions and their contraceptive behaviour. It's not necessarily that they don't want any more children. It's just about having the ability to control your fertility.
Yeah, and I think that's really important. It's not about necessarily limiting family size, but actually giving women choice about when and if they want to have more children, I think is the key thing.
Yeah.
When we look kind of globally, there's just a huge unmet need for contraception. So out of the 923 million women of reproductive age in low and middle income settings, we think that around 218 million women of reproductive age, and these are women between 15 and 49, have an unmet need for modern contraception. And we know from looking at those maps earlier, that the burden of this unmet need certainly falls disproportionately on women in low and middle income settings. More than half of this is in sub-Saharan Africa and South Asia, as we can see on the maps. And this isn't to say that we don't have issues in high income settings. I know that sexual health services in the areas that I work still struggle with how they're structured and how we can ensure that their barriers to access are removed. So this isn't a problem that is solely related to low income settings. It's definitely a global issue.
Yeah, absolutely. And I was looking for some statistics on this actually, and the most recent ones were in 2021, and that over 6% of women in Europe want to stop or delay childbearing but are not using any method of contraception. The unmet need for family planning was especially high in Southern Europe, where 11% of married women were not using a contraceptive method, yet wanted to stop or delay childbearing. Northern and Western Europe, on the other hand, showed lower rates of unmet family planning needs. So as you say, it is a global issue. Probably very much depends on your community where you're growing up within each country anyway.
Yeah, I definitely agree with that. And we know that when you have a lack of access to quality contraception, both the counselling aspects, the information sharing, and the physical supplies, it has far-reaching implications and consequences for women and both girls in terms of their health and their rights, including good gynecological health. And good gynecological health and contraception is really important. And I think the women's health agenda is reaching the right areas in terms of key kind of policy makers. But it's incredibly important because when women lack access to contraception, it removes their means of the ability to make important life decisions, including whether or when to become pregnant. I know we have gone back to the low and middle income settings, but the burden is disproportionately weighted on these settings. And just under half, so 49% of pregnancies in these settings, which amounts to 111 million annually, are unintended. And we know when you've got a high rate of unintended pregnancy, it means a high rate of maternal mortality and morbidity, high rates of unsafe abortions. And actually, it's all about us not limiting the ability for young people and women to make those healthy decisions regarding timing and space in their pregnancies. And there are lots of things we can do to help improve women's health, such as keeping women in primary and secondary education for as long as possible. But delaying their first pregnancy is a key intervention for the prevention of many physical and psychological complications, including obstetric fistulas and other issues that we've touched on above.
Yeah. So there is some good news out there in terms of the unmet need. Family planning programs, such as in India, have responded to high levels of unmet need through an array of measures, such as improving the variety and mix of contraceptive methods used or available, enhancing their availability, improving the accessibility and the affordability of contraceptives. The affordability is another really important issue in terms of this. And crucially, boosting the capacity among family planning workers to connect with women from marginalised communities and respond to their family planning needs. You mentioned this before, the data maps, Rob, between the maternal mortality and the unmet need. And we can see that there's a strong correlation between the two in the areas of high mortality and also for the high unmet need for contraception. It's quite a useful visualisation of the problem, isn't it?
Yeah. No, I do think it really highlights this correlation between the two.
So not only does family planning make health sense for mothers and children, but it does make that sense in other ways. Satisfying the global unmet need for family planning reduces maternal deaths. It's estimated by about 30%. So that would mean, in real terms, 22 million fewer unplanned pregnancies, 50 million fewer unsafe abortions, and 90,000 fewer maternal deaths. Preterm birth, low birth weight and stillbirths are more common when pregnancies are closely spaced. So obviously it would have an impact on this. And family planning, as you've said, it saves lives, both of mothers and of babies.
And I think as healthcare professionals, often our prime role and vocation in what we do is about the patient in front of us and getting the best possible kind of life outcome for them. But aside from the making sense on the health front, it also makes economic sense. So if you're someone that is in a role that is more concerned with making sure the budgets and the sums add up, It's really important to understand that for every dollar we spend on family planning, particularly in low income settings, it saves $11 in treating pregnancy and its related complications. So it's really important that we make health policy makers aware of both the health benefits, but also the economic benefits of
Mm,
investment in programs that support contraception.
absolutely.
In order to avoid maternal deaths, it's vital that we want to aim to prevent unwanted and mistimed pregnancies. And with the right contraception, almost all of these unwanted and mistimed pregnancies could be prevented. The postpartum period is an important time to provide effective contraception, and it provides us as healthcare providers a unique opportunity to make a difference during that time period. And as we said at the start, all women, irrespective of their age, should ideally leave the birthing facility with a minimum having had the opportunity to discuss and be offered a method of contraception. And although it's one small thing, it can make a really big difference.
We've talked about the interpregnancy interval. The WHO recommends this interval of being 2 years. And there is some reason behind 2 years. If couples aim to space their children more than 2 years apart, 3 in 10 maternal deaths could be avoided. 1 in 10 child deaths could be avoided. If current average interintervals were increased to a minimum of 2 years, 100,000 infant deaths could be prevented every year. I mean, it's quite helpful, I find, to put to look at these numbers, because you realize that, like you say, a small thing in terms of family planning can have such a massive impact in preventing morbidity and also improving family lives.
It's useful sometimes to have both that perspective on an individual level, but also it's useful to gain that wider understanding of actually the huge impact in terms of hundreds of thousands of lives at a population level. So I think
Mm.
it's translating both that individual clinical role and that slightly kind of wider public health perspective, and trying to enable the two to be incorporated into our learning is really important.
Yeah.
And the thing is, with this 2 year birth interval, whilst there are lots of different options for contraception, we know that women are most likely to achieve this interval of 2 years if they have a long acting reversible contraception method. And we're going to discuss the long acting reversible contraceptive methods in a little bit more detail later on, I think, in the next module.
Yes, we're going to discuss all contraception. So I know this is an exercise that you do when you're giving courses on postpartum family planning, to think about the benefits from everyone's perspective. So it's an exercise that you can do with your colleagues at work, and just to help you think about all the benefits and just give you that extra motivation to make sure that any woman in your care, as you say, Rob, has at least the chance to discuss contraception before they leave a birthing facility.
Yeah, and I think it's worked really well if you have the opportunity to share this with colleagues, that each group or individual takes on the perspective of one of the kind of the stakeholder groups, or the persons that we're trying to show the benefits for. So for the mother itself, the person that we often think about most, there are the immediate kind of health benefits of reducing the risk of complications in another pregnancy. But more than the direct clinical benefits, it's looking at the social benefits to allow adequate time for the new mother to take care of the baby and for herself. And it contributes to preserving both the health and fertility of a woman, looking overall at their quality of life. And in absolute terms, it decreases a woman's work burden. Actually, the difference between looking after, say, 3 or 4 children, all under 4 or 5, versus looking after 1 or 2 children under 4 or 5 has a massive impact on their daily life.
Absolutely. And if you're looking at the newborns themselves, it's again looking at it from a health perspective. They're at a reduced risk of dying and of even being a stillbirth when the mother has fewer young babies to look after at one time. Hopefully this will promote prolonged breastfeeding and improve bonding between her and the newborn baby. As we've mentioned, it reduces the risk of prematurity and growth restriction, but also, again, from a sort of economic aspect, it contributes to improving children's lives by increasing their access to adequate food, because there are fewer mouths to feed at any one time, access to clothing, housing, and education opportunities, as you mentioned as well before, Rob. All these things, just the simple thing of spacing the pregnancies more, it opens up a massive amount of life opportunities.
The one thing I also think is really important is that we do think and involve fathers and men in these discussions.
Mm,
And although I'm a massive advocate for women being in control of their choices, particularly in relation to reproduction, in many settings we do have to acknowledge the impact that men can have on these discussions. And I think it's really good to consider and explain the benefits to fathers about birth spacing as well, because again, it promotes kind of family relationships from an economic perspective. It reduces the financial burden on the family, and it enables perhaps the father in many settings who may be the main wage earner to safeguard both the health and well-being of his wife and his children, and consider those implications about what it means for their long-term planning. I remember I did an essay competition in Sierra Leone when I was very young, and about how to improve maternal morbidity and mortality.
mm,
And one of the students wrote a wonderful thing that said a father should not be judged by the number of children he has, but
mm.
by the health and quality of their education. And I thought this was a really quite a powerful thing. This was one of our nursing students that wrote it, and
Wow.
it just, yeah, it definitely kind of resonated at the time.
Yeah, that's fantastic. And I think, when you were describing the lady that you had before who was on her ninth pregnancy, the impact of her being in hospital for the month, you said, and the impact for the father, assuming there was a father back at home with the other 8 children, and the impact that had for him, being aware that the birth spacing is going to help in so many ways. You do need to include them. They're very much part of the decision-making process.
Yeah, and I think when we're both busy as healthcare professionals, but families are busy with multiple kind of aspects to everyone's lives, it is important to really explore these wider benefits, which then enable people to buy in and give these discussions the time they need to, when it's explained to them actually really what this potentially small investment in discussion and time will mean in reducing these risks of really potentially quite severe impacts on their whole family life in the
Mm.
future.
Yeah, which brings us beautifully on to the next group, looking at the benefits for the family. I mean, I'm not sure I really need to say much more than you've already said, but just to reiterate that it means families can devote more resources to provide the children with food and the adults with food, clothing, housing, education. It improves family bonding because you've got more time. And again, thinking about the financial aspect of it, good family planning alleviates financial hardship.
Definitely. When you take that even slightly larger step back from the family setup, even to the wider community, actually has a big impact on how the community functions, both very practically reducing the risk of death and illness, and that has a role to play in poverty reduction and improvements of quality of life for the community as a whole. But it also protects against the economic, social, and environmental pressures of populations that grow too rapidly, too quickly, and the impact of their meeting the health needs of that rapidly growing population,
Mm,
which can have a big economic impact. I often think of in settings that I've worked where you've got one or two very hard-working midwives,
yeah.
and when I've taught, you see them look at you initially and saying, "Rob, why are you trying to get me to do another thing? Can't you see how full my hands are with delivering these babies, keeping the women safe? And now you want me to talk about contraception as well?" And I think one of the things that I try to do is explain to say, well, actually, unless we do this in a
You're
nine
just
month
going to
or a
get
year's
busier.
time, you're going to have more work because these women are going to be back having their fourth, fifth, sixth baby. So
Mm,
sometimes with our colleagues, we have to sell the idea that actually it's also beneficial to them in terms of actually helping birth spacing, because it reduces their workload, that they won't see the woman again, hopefully for 2 or 3 years rather
yeah.
than a year's time.
Yeah. No, that's a really important point. So when should this family planning start? There are a few things to think about, and I'm just going to ask the questions and let you tell us the answers, Rob. When do couples resume sexual intercourse after a baby's born?
So probably often sooner than we think. For some couples, it's within 4 weeks, some kind of
Mm,
4 to 6 weeks. It's something that often we don't feel very comfortable discussing,
yeah.
but it's important to recognise that perhaps happens earlier than we anticipate.
And then the next very important question is, when does the woman become fertile again after childbirth? Because obviously that's pretty crucial.
Exactly. And it does depend on whether the woman is exclusively breastfeeding or not. And again, it's probably earlier than most people anticipate. So if a woman is not breastfeeding, usually they become fertile before kind of 6 weeks,
Mm.
and they can often ovulate sometimes as early as 3 weeks, but usually within the first 45 days. And
Oh.
most non-breastfeeding mothers, their periods resume within the first 12 weeks.
So I guess you could easily be ovulating and have no idea and become pregnant very quickly after you've given birth.
Yeah, and I think that's key in that women can't have the protection of thinking, oh, I'll wait till I see my first period
Yeah.
and then I know that I'm fertile and then I'll think about family planning. But often women don't have that warning sign that they may well ovulate first without knowing that they're fertile and then conceive potentially very early kind of
Mm.
postpartum. If women do choose to breastfeed, often the fertility returns much later, but it all depends on the frequency of the feeding
Mm.
and whether there's any supplementary feeding. So, if a woman is exclusively breastfeeding, then it can be up to 6 months until the fertility returns. But as soon as she's breastfeeding fewer than 6 times a day or add in supplementary feeds, the fertility may return much sooner.
So, for example, if the baby is unwell and not feeding as frequently, that could quite easily impact that protection.
Yes. And I think later on in the subsequent modules, we're going to talk a little bit about the kind of the role
Yeah.
of lactational amenorrhea method.
Yeah.
But the key thing is to make sure contraception is in place before ovulation. And that's why this postpartum period, particularly the immediate postpartum period, is such an important window.
Yeah.
And the most convenient time to provide it is really at the time of birth and certainly before she leaves the birthing facility. But you have this window, and sometimes once the woman returns to her home that may not be near, suddenly contraception gets forgotten about. It may be harder for them to come back to the clinic, and we've lost that opportunity.
Yeah. So that's really starting to answer the sort of next question that I would ask you, which is what are the opportunities that we have for providing postpartum family planning for these women?
I almost think kind of every time I have an encounter with a woman who's pregnant or been recently pregnant, we discuss contraception. I'm sure the colleagues that I have learning in my clinics get fed up with it, but there are very few times we can't or shouldn't discuss contraception. But certainly when we're seeing women in our antenatal clinics or
Mm.
on the ward and discussing their pregnancy or any complications, but often in some settings where women are coming to waiting homes near the hospital prior to delivery, there is plenty of time to explore contraceptions. I think on our labour wards and certainly on our postnatal wards, there's opportunity. I think the only one time that we shouldn't discuss contraception is when a woman is in established labour. I think we need to be mindful of her needs at that point in time. So I think it's inappropriate when a woman is
Yeah.
having regular painful contractions to go there. But aside from that, even when women come in some settings to have their labour started, so an induction of labour, at that point in time, I think it's still appropriate if no one has talked or touched upon contraception,
Yeah.
still reasonable to have a conversation at that point in time to at least sow the seed and potentially make a plan for that period after birth.
So if someone has an abortion or if they have a stillbirth or even a neonatal death, at what point would you be discussing, would you still try and discuss contraception with them? Because obviously it's really important in those circumstances.
It is, and I think there's certainly a role for it. We always need to be mindful about the sensitivity of
Mm.
these discussions and the timing of these discussions. And I think depending on the situation, it's appropriate sometimes to do some soft signposting with information sharing. But I think it's a little bit context dependent,
Mm.
but also it's making the most of that encounter you have with the woman, regardless of the circumstance. It may be that in some settings, that is the only opportunity a
Yeah.
woman will have for those discussions. So, although it can be hard, I think with the right communication skills, usually in most settings, it can be addressed. Although I appreciate that after a loss of a wanted pregnancy, when women may want to aim to conceive very quickly,
Mm.
these can be quite difficult conversations.
Yeah. Yeah. are other opportunities that aren't necessarily birth related. So at other clinics, be like at a child immunisation clinic, outpatient departments, on the paediatric ward, outreach clinics. There are lots of other opportunities, aren't there, to be able to talk to patients about family planning.
Yeah, and I think the key thing is that most healthcare professionals treat both men and women of a variety of ages. And contraception is one of those things that does filter into so many specialties, whether you're working primary care or whether you're a neurologist dealing with women who have epilepsy. Actually, the role of discussing and talking about contraception isn't just for gynecologists or obstetricians or reproductive health specialists. It is really everyone's responsibility to have that bit of knowledge and awareness to impact on those choices.
Fantastic. We have a little infographic which shows varying times where people will have contact with healthcare professionals and points of giving advice and possibly contraception. So offering modern contraception as part of childbirth services increases postpartum contraceptive use, and it maximises the available human resources at the facility to offer the family planning. Interestingly, and I'm sure this is probably quite a frustration for you, Rob, most women do not use contraception postpartum. So among the annual 230 million pregnancies in the world, 45% are unplanned and maybe unwanted. And almost all women, so about 95%, want to avoid a pregnancy in the next 2 years, but only 30% of them are using family planning. So the reasons why women or men as well are not using contraception is manifold, and each needs a bit of a different approach, I suppose.
Yeah, and there are many reasons for this. For some women, they're unaware on the need to use it. For some, there are issues in relation to cost or the knowledge of where to get it or how to get it. Sadly, sometimes women are not informed appropriately by the health provider, and us as health providers sometimes are unaware of the options that are available. There can also be kind of family pressures on avoiding it and the wish to rely on breastfeeding. And given that there are lots of options, sometimes there are issues around people not knowing how to use their specific method of family planning. It's really worth remembering that whilst healthcare providers on the front line can't always address all of these structural issues, we do have a key role in counselling, providing information, and by offering and providing postpartum contraception in a timely manner, we can have this huge impact preventing maternal and infant deaths and morbidity.
Fantastic. Thank you, Rob. That was really interesting, and I'm really looking forward to part 2, where we will be discussing the actual family planning methods, their relative effectiveness, eligibility criteria, and how you can help your patients make an informed choice. Now, I've really enjoyed doing this part 1 with you, Rob. I hope you've enjoyed joining us today.
It's been a pleasure, and thank you for the opportunity to be able to share this passion to hopefully improve reproductive choices in this time period.
Thank you. And thank you for listening. Remember, you can download the supporting notes, complete the CPD quiz, and receive your certificate at www.horizonmedicaleducation.com. If you found this episode useful, please share it with your colleagues and follow us for weekly episodes. Goodbye.